of medicine, in the division of nephrology. Tony has done some incredible work both in that's your new talk, okay? In renal transplant, but also in the physiology of, and I don't, here it's found it, of sickle cell glomerular damage, showing the mechanisms of action of glomerular damage. Boy, the son of a nephrologist should be able to say glomerulus better than that. In causing renal insufficiency and looking at the role of microalbuminuria. He's going to talk about renal insufficiency in sickle cell disease, if we can get his slides up. And where's my computer? And which one is one? Patriot. Is that Patriot to Catalan Nation? Or Patriot
no, renal complications, I think 11, yeah. All right, thank you. Well, thank you very much, the organizers. It's both a pleasure and a privilege for me and an honor to be at this symposium. And when I was putting these summary slides together, I thought that rather than doing overall review of renal manifestations of sickle cell disease, I thought of putting a little bit of history of how our knowledge evolved. First, when I started talking with Jim about kidneys in sickle cell disease, and with his ideas, support, and encouragement, how we have advanced while at the same time serving the needs of patients at the sickle cell center. So I'm going to start with a case presentation that exemplifies the state of care and recognition that we had in the mid-90s in people with sickle cell disease. I hope you can see it from the back, but I'll briefly read it, that it was a 37-year-old. Let's make it bigger.
Put it way up on Oh, is this? Okay. I guess you're going to have to go over there.
Give me a second, see if I improve. Yeah, hopefully a little better, huh? So a 37-year-old female who was referred to the renal clinic at Grady in 1996 because of renal insufficiency with a serum creatinine of 2.1. She had hemoglobin SS, had several complications throughout the years. She was on folic acid, acetaminophen, hydrocodone as needed. She was borderline hypertensive by standard criteria, BMI 21, no significant findings on examination volume-wise. Laboratories, you can see hemoglobin 8, potassium 5.6, serum creatinine 2.1, albumin 3.5. By UA, she had 2+ protein, a little bit of blood, but no red blood cells by microscopy, and occasional hyaline and granular cast. A 24-hour urine collection was done to quantify renal function. She had about 1.4 grams of proteinuria, a clearance of 23 mLs per minute, and by ultrasound, she had small echogenic kidneys. With that information and other workup, she was diagnosed with sickle cell nephropathy. Patient was started on calcium channel blocker, sodium bicarbonate to control hypertension, metabolic acidosis. Later on, a loop diuretic was added to control hyperkalemia. Renal function continued to worsen, and 9 months after referral, she was started on hemodialysis. 4 months after hemodialysis started, she presented to the Grady emergency room, severe vaso-occlusive event, rapidly resulting in hemolysis, hypotension, severe hyperkalemia, and she expired several hours after admission. So this is an example of the time this disease was detected, the lack of effective treatment options, and the poor outcome after the initiation of dialysis. And I'm not going to talk today about tubulointerstitial disease and other complications of sickle cell nephropathy, but I'm going to focus on glomerular disease. And I remember coming to Emory and meeting as part of my interview process with Jim Ekman, and I didn't know much about sickle cell disease and much less about sickle cell nephropathy. And I remember him telling me that clinically what we see is early hyperfiltration. Then some patients develop proteinuria, progressive renal failure, and they develop end-stage renal disease. So what I'm going to talk with this background is work that we have accomplished here, talking about the clinical presentation and early detection. I'm going to talk a little bit about mechanisms of glomerular dysfunction, and then some potential genetic markers and therapeutic aspects. So when I came here, I thought, well, you know, if we had to work on a grant, if we had to put something together, we have to give some prevalence of the problem, how important the issue is. So I remember I asked Dr. Ekman, and I said, so where you keep your records? Because don't forget, there were no computerized records. He said, oh, we have the charts here in the back room, so you can go there and find them, and then just go over the charts and see what you can come up with. So I did, and 681 adult charts later, I found 342 charts where they had urinalysis paper trail. And when I look at abnormalities in the urinalysis, I look for proteinuria, either 1+ or more than 1+. And I found 67 patients that had some proteinuria out of the 342, so a prevalence of 19% in the adult population. I said, well, 20% sounds good, but maybe they have more renal insufficiency. So out of these 681 patients, 342 had paper trail with serum creatinine, and then I said, well, how many patients have a serum creatinine more or equal to 1.4, the upper limit of detection based on the computer report at that time at Grady? And I found 15 patients, and they said 4%, and I said, 15 patients out of the whole center, we are not going to do too well in here. But one of the things that I learned and I wanted to determine is how good these estimations of renal dysfunction, renal insufficiency are in patients with sickle cell disease. And I'm going to show you some data that we gathered at the Sickle Cell Center over the number of years. It's mostly in adult patients that indicates the deficiencies of the current methods to estimate renal function. And just to summarize a little bit, you know, we can estimate it through serum creatinine. There is some evidence in cystatin C, but the results don't seem to be much better, at least in adults, than serum creatinine estimation equations. And then we can measure creatinine clearance either in a time collection or through formulas that are based on clinical factors like gender, age, weight, etc., or derived from studies with progressive kidney failure, which are the commonly used estimation equations. One of the things that we did was to plot the relationship between serum creatinine and GFR in adult patients with sickle cell disease. And what you can see here is the well-known hyperbolic relationship between the two factors, so that as renal function worsens up to a certain degree, then the serum creatinine is very sensitive to detect renal insufficiency. So when we plotted the upper limit of normal at that time of 1.4 serum creatinine, we saw that the serum creatinine only detected abnormality in GFR when it was down to 25-30 mL per minute. Once it becomes abnormal, it's very sensitive, as I said, but before the serum creatinine becomes abnormal, you have a large range of values in true GFR. Then we said, well, maybe patients with sickle cell disease should have a lower limit. This is before all the new information came out on normal serum creatinine values. So we lowered the bar and we brought it down to 1. And you can see that you can pick up other patients that were deemed normal by previous equations, but still you have to get down to 50 mL per minute. And you could keep lowering the bar, and you bring it down to 0.8, and you will have a slightly higher sensitivity. But none of these equations is going to deal with the problem that between 60 and 125 or 150 is a flat line. And this is not just related to some systematic or percentual change in the handling of creatinine by the tubules. This is something that deals more with a complex phenomena of serum creatinine values in renal function. This may not show too well because it's in this kind of light green. But in here we measure simultaneously the creatinine clearance in a urine collection and the inulin clearance in the same set of urine collections. So there is no errors in a way of collections. And you can see that most of the values of the creatinine clearance are above the identity line. But it does not follow a simple mathematical relationship. There is a huge variability in the overestimation by the creatinine clearance of the true GFR, and this is specific in sickle cell disease. So we went a step further, and then we said, well, let's look at the state-of-the-art estimation equations, and this applies to adult patients only, and see how accurate these formulas are predicting the true GFR. And there is a technique that is called the percentage prediction error. So you can say, this is the true GFR. You can determine 10% above and below the true numbers, 30% above the true numbers, and 50% above the true numbers up and down as to how many of those patients are going to fit those criteria. And that seems to be like a complex slide. It is not. Because since I have trouble sometimes remembering numbers, I just memorize the mnemonics. So no matter what equation you use, abbreviated MDRD, Cockcroft-Gault, CKD, EPI, which is the one that we should all use according to guidelines, you have 10% of the error is only 10% of patients, roughly. 30% error, remember, 30% of patients. 50% error, remember, 50% roughly of patients. So it tells you that if you want to be within 30% of the true GFR, any of these estimation equations only going to catch 30% of the patient population. Big problem. Then you say, well, let's restrict it to patients with renal insufficiency, GFR 30 to 89 by inulin clearance. The numbers improve a little better. You may have 10 to 20 for 10%. You may get 30 to 50 in some cases, with 30%, I should say, and 50% you increase it a little bit higher. But the variability is huge. So it's a problem. I just realized that more than 50% error, you see that is still a significant number of patients. So the variability is huge, and you can say, well, it's not that accurate. And I would say, well, it's not just not accurate, that if you do epidemiological studies in sickle cell disease, you're going to have a problem, because you're going to think there is no problem when there is a problem. So this is, I'm a graphics person, I like figures. So here I plotted what it's a box plot of the 75th, 50th, 25th percentile, and 90 bars of the true GFR of the patients, over 150 patients, if I'm not wrong, adults, that we analyze. And this is the same box plots for the different equations. Walser, abbreviated MDRD, Cockcroft-Gault, CKD-EPI. And remember, CKD starts with 89 or less. You can see that a lot of patients have a GFR of 89 or less. But if you use these equations, you're going to miss about 75% of the individuals. Big problem. You do epidemiological studies, CDCs across the street, you're going to miss 75% of adults. But I'm going to go a little beyond GFR. And I'll say, well, even if you measure GFR, is this the ultimate test of glomerular function? And just, I realize that this I'm the fourth speaker for the morning, so maybe a little tired, but just two basic concepts about renal physiology. And remind you that GFR is not a fixed number. It's a number that varies according to a combination of pressures and flows across the glomerulus. But there are techniques, there are physiological techniques that we can use to separate the contribution to the GFR of the pressures and flows, and then the intrinsic ability of the glomerulus to filter, what something is called KF, and this is shown in here. And that's important to know because you can increase GFR by increasing blood pressure, or you could increase it by increasing blood flow, modulating by decreasing blood flow, like we see in clinical settings all the time. So one of the things we wanted to know is, what's the mechanism of renal insufficiency in sickle cell disease? It's because you have microvascular disease in the medulla, you have some interstitial problem that you cannot then filter for some of the mechanisms. So we look at those determinants of glomerular function. So we had a group of patients who had normal GFR, and we have a group of patients with sickle cell disease who had renal insufficiency. And what we saw that the major determinants of low GFR was a reduction in the renal plasma, renal blood flow, but also a major reduction in the ability of those filters to filter blood, something that is indirectly estimated by what's called the filtration fraction, which is the relative percentage of blood flow that is filtered into final urine. So by doing this analysis, we could tell for sure that the main problem in patients with renal failure was a reduction in the ultrafiltration coefficient. And then we tried to go a little step beyond that point and see what would be the significance of early albuminuria in this population using these physiological techniques. So we took a group of patients with sickle cell disease who had albuminuria, abnormal albuminuria I should say, but had normal GFR measured by inulin clearance. We compare it with a group of normal albuminuric sickle cell individuals and also normal GFR, and with a group with renal insufficiency. And what we found is in those patients with albuminuria, abnormal albuminuria, who had still normal GFR, we saw that that albuminuria was associated with a significant drop of about 40% in the intrinsic ability of the glomerulus to filter water and waste products, that it was unrecognized by the measurement of true GFR because of hemodynamic adaptations. So we thought, well, maybe now we have a tool that we can use to detect early involvement in sickle cell disease. And then we thought, well, we should not restrict ourselves to adults, even though I'm an adult nephrologist, said this something potentially could be used in pediatric and in adult patients. And that concept generated collaboration in the pediatrics department that I still have to date, and I hope to continue in the future, because it exemplifies the importance of a comprehensive approach to a disease that starts at birth and maybe even beyond that. So with this type of analysis, we plotted, this is data summarized, I think it's 700 or 800 pediatric and adult patients with sickle cell disease SS, and looked at the prevalence of normal albuminuria at the age of 2 to 6, 7 to 12, teenage years, early adulthood, middle adulthood, or there'll be some differences of opinion in this room as to what's middle adulthood and older age, or I'm going to leave it out of my biases in here. But just to exemplify that while a majority of children with sickle cell disease have normal albuminuria, a significant percentage of them, they already have microalbuminuria. These numbers drop the normal albuminuria significantly with age, while the prevalence of microalbuminuria increases with age. And then in the teenage years, you start seeing children who have macroalbuminuria, and that percentage of prevalence increases significantly as time goes by. And this exemplifies the fallacy of thinking that only 20% of patients adult patients with sickle cell disease have abnormal or abnormalities in the urinalysis, when it's 80% of patients who are over the age of 40 with hemoglobin SS have evidence of renal dysfunction. Again, this is an underestimate, most likely because this is not a cross-sectional longitudinal analysis of patients, but it is, I should say, not a longitudinal cohort that's been studied from birth, but it's a cross-section of different age groups, and there have been people who have been lost due to comorbidities and may have not made it to those ages. And another concept that I want to introduce here is that maybe we can go a little beyond albuminuria and show that even in patients who have no abnormal albuminuria by current methods, we saw that a lot of these patients have an early abnormal increase in permeability at the glomerular level of dextran macromolecules that are normally restricted up to a certain level at the glomerular capillary wall. So while in healthy controls, non-sickle cell patients, this is the pattern of restriction and permeability in white, patients with sickle cell disease who have normal albuminuria, they have already increases in glomerular permeability that have not made it into the microalbuminuria range. So what happens to the glomerular pathology? And I want to show this briefly because I think it gives us puts us in a state of mind as to how we need to look at this disease in the future. If you go through the literature, the early descriptions in the 60s and early 70s emphasized a membranoproliferative type of glomerulonephritis. And people didn't know if it was related to infections, hepatitis C, other viruses that could give this type of pattern. And it was kind of abandoned in the descriptions. And more recently, the emphasis has been based on a report by Falk and co-workers about 20 years ago now, in the New England Journal, there would be glomerular hypertrophy and FSGS, and the authors postulated that it was a wear and tear type of lesion associated with hyperfiltration at the glomerular level. So a lot of people then lost interest in this pathology because it would be like a secondary form of FSGS related to increased hypoperfusion. But let's not forget that pathologists give us names, but many times they do not describe mechanisms or the actual pathophysiology of the disease. And this is just to show differences in patients with focal segmental glomerulosclerosis associated with obesity and or single or agenesis of one kidney and hypertrophy and hyperfiltration of the other one, with those of sickle cell nephropathy. Just visually, the diseases look differently, even though they both have the same pathological diagnosis. And what we tried to do in a limited number of patients that had a kidney biopsy was to study the contribution of the different components of the glomerular capillary, of the glomerulus, to the alterations that we see in function. And just to emphasize that these are glomerulus, so we can quantify the glomerular endothelial cells, mesangial cells, podocytes, all the structures that you see here using histomorphometric analysis. And this is an example of photomontages of glomeruli at a certain magnification where we can actually define the different cells and the different frequency distribution of those cells. And what we saw is that in sickle cell anemia, there are significant alterations both in mesangial cells, here in red. There is a loss of glomerular epithelial cells, the podocytes, and there was a significant increase in the number of endothelial cells and endothelial cell nuclei. Then we said, well, maybe we can look at secondary forms of focal segmental glomerulosclerosis, and we took 7 or 10 patients, I think, that had agenesis of one kidney or obesity as a cause of the focal segmental glomerulosclerosis, which typically causes hyperfiltration and hypertrophy, and we look at the findings in sickle cell disease and non-sickle cell secondary focal segmental sclerosis. We had the same volume of glomeruli, so there was no differences in hypertrophy. The degree of sclerosis was similar. And when we look at mesangial density, it was also similar to the two diseases, but the striking difference in sickle cell disease and other types of focal segmental glomerulosclerosis was the number of glomerular endothelial cells that were more than double in patients with sickle cell disease. Oh, I think I hit the wrong button, so my apologies. So when we quantify it in a graph form, we saw alterations in secondary sclerosis and sickle cell disease in red that primarily as a more pronounced drop in podocytes and a marked increase in the number of endothelial cells. So if it's FSGS with nothing else, it's a different type of FSGS than the one that we see with hypertrophy. So let's talk briefly about mechanisms of glomerular dysfunction, and I'll show you a negative study and then a little bit of my encouraging study, just to emphasize that what we do and what we should present is not like the positive findings. We have negative findings, we need to present it too. That's in fairness to science and to the audience. So, you know, initially when I saw this dysfunction, increase in flows, increase in permeability, I said, well, this sounds like a chronic activation of the nitric oxide. So I think I know what the mechanisms is. I'm gonna regulate permeability by blocking nitric oxide, then I'll be able to say it's nitric oxide, and then maybe people will think of me when they think sickle cell disease. So the question was nitric oxide system mediating the permeability? We did functional studies where we measure glomerular hemodynamics and glomerular barrier function using permeability of dextran. And we did before and after the infusion in individuals with sickle cell disease of a suppressor dose of a blocker of the nitric oxide synthase, LNMMA. So this is the results in controls in blue, healthy controls, and patients with sickle cell disease in red. And when we use the suppressor dose of LNMMA, we had a slight non-significant increase in mean arterial pressure. We did not significantly modify the glomerular filtration rate by study design, but we had a slight decrease in the renal blood flow, even though we used a suppressor dose of LNMMA. And that was associated with also an increase in the filtration fraction. So a higher percentage of blood flow was resulting in GFR, probably related with changes in vasoconstriction at the glomerular level. So when we look at the permeability, what we saw is something very interesting. In healthy controls, here in blue, before LNMMA, we had a certain degree of permeability. When we infused LNMMA in healthy controls, we saw a reduction in permeability to macromolecules that was associated with modulation in the pore size at the glomerular capillary wall. That's something that I'm not showing here. However, when we look at patients with sickle cell disease, there was no change in permeability. So to my dismay, what we show is that the changes in permeability that occur in sickle cell disease are not related to, or cannot be reversed by blocking the nitric oxide synthase at the dose that we use. A dose, by the way, was enough to reduce nitric oxide metabolites in the urine in both healthy controls and in sickle cell patients. What about therapeutic interventions? And that leads to the last 5 minutes of the talk. We know that there has been attempts at modulating proteinuria in the short term with renin-angiotensin blockade, initially with ACE inhibition, by Dr. Falk and co-workers, published a number of years ago, where they used low-dose enalapril in 10 patients, and they were able to reduce proteinuria by 50% without affecting blood pressure or GFR. Here we initiated a similar pilot trial that initially had 16 patients, and now we have extended to 28 patients, the observations, but they have not been analyzed at 28 patients with permeability studies yet. And we were able to show that albuminuria is also reduced by 40–50% without changes in GFR. And this is shown in here. We can see that patients on losartan at 100 milligrams per day had no significant reduction in blood pressure in these patient studies, no changes in GFR, no significant changes in blood flow, no changes on cardiac pressure, but the albuminuria was reduced by about 40% based on median values. Again, emphasizing the ability to modulate the permeability. What's the significance of this reduction of proteinuria? We're going to need to have longitudinal studies, but we know in other studies that the acute changes in proteinuria with any therapeutic intervention is associated with lesser degrees loss of GFR of the ensuing year. So if you have a 50% reduction in proteinuria, for instance in diabetic patients, with a certain intervention, you can slow down the rate of loss, the subsequent rate of loss of renal function. So some ideas about clinical markers. I showed you the importance of albuminuria. I think it's worth studying the contribution maybe of early dextran permeability changes as a predicting of those patients who are going to develop albuminuria later on. We looked at genetic markers, and I'm going to show you only the results, the summary rather than the results because of time. We look at alpha globin microdeletions, and we show that they were renoprotective. People who had the microdeletions in the alpha gene, despite having same hemoglobin levels, had much less incidence of albuminuria. We could not see difference in beta globin haplotypes in the prevalence of kidney function or dysfunction, looking at Central African Republic, haplotype, etc. And then we look at the renin-angiotensin system with the microdeletions of the with the IV polymorphisms of the renin-angiotensin system, and we did not see differences in the prevalence of albuminuria. So I think genetic markers is still work in progress. Alpha thalassemia coexistence is something that's been known in general, affecting the clinical severity of the disease, and we showed that had a clear role protecting the kidney. And just because of time constraints, let me go to a summary slide where we went from that patient that was referred and died within a year and a half in 1996 to a hopefully a much more systematic approach where maybe be able to look at genetic predisposition. I think the evidence is clear that annual albuminuria determination should be part of the standard of care of children and adults with sickle cell disease, and interventions may be needed at an early stage. Even though the estimation equations are limited until we have better ways to estimate renal function, we should use some estimation of GFR to determine renal insufficiency in this population. Need to monitor blood pressure, and I think we have to critically consider whether the target blood pressure values for the general population should apply to the sickle cell disease population. I think there is strong evidence, and other people have talked and probably will talk about it. Anti-sickling mechanisms using hydroxyurea may be beneficial in kidney protection. In some cases with advanced renal insufficiency may be given together with erythropoietin. I told you about the role of angiotensin blockade in albuminuric patients. correction of metabolic abnormalities. And then just a word about kidney transplantation. Outcomes of patients on dialysis are below. I couldn't find the slide. We published this last year in, I think it was the American Journal of Hematology, if I'm not wrong, that the outcomes of hemodialysis patients who have sickle cell disease are much worse than the patients who don't have sickle cell disease adjusted for comorbidities. And it tells us that we need to look at how we dialyze patients with sickle cell nephropathy, sickle cell disease, but also offer them the hope of kidney transplantation as renal replacement therapy. Dr. Larson is not here now, but we have a pilot program where we look at patients with sickle cell disease and sickle cell nephropathy who need a kidney transplant. We have early interventions using a transfusion program in the first 6 to 12 months post-transplantation to minimize sickling, and once they are on lower dose immunosuppression to prevent the rejection of the kidney allograft, we put them on hydroxyurea therapy. We have several patients that have been done with this approach, and they've done very well. And then also mention an ongoing a project that we have with Dr. Marianne Yee McPherson that I'm not so sure I don't see her right now, but we've been collaborating extensively in the last year or so, where we use combination therapy with hydroxyurea and losartan in early albuminuric patients with sickle cell disease to see if that intervention may reverse the abnormalities and restore function in this patient population. So with this, I'm going to finish and thank you, and thank especially Dr. Ekman. He was my mentor in sickle cell disease. He was also source of funding in stages with sickle cell nephropathy, and it's been a model to imitate, and I think a model to emulate for most of us here in the audience, because we need people like him to follow his footsteps so we can improve in the delivery care here in Georgia and elsewhere. Thank you very much.